I'm Anthony Leeds, and it's my pleasure to welcome you to this discussion on topics relating to how we address the problems of obesity and overweight and the various ways in which we can help individuals. And we're particularly focusing, of course, on diabetes in this series of discussions. And you've heard already about how a dietary program that's been developed in Newcastle and in Glasgow has been able to put people with a recent diagnosis of diabetes into remission. But long before that experimental work was done, it was known that using bariatric surgery would help quite a proportion of individuals who have diabetes. And with me today is Mr Pratik Sufi, who is the consultant bariatric surgeon at the Whittington Hospital in London. And we're going to discuss some of the issues around the use of bariatric surgery for those people with diabetes, but for others as well. Pratik, thank you very much for joining me today. Let's begin with that question of what type of bariatric surgery is appropriate for people with diabetes.
Thank you, Tony, for inviting me to this show. So all bariatric surgery has beneficial effect on the diabetic patients in helping them control their diabetes better and putting them in remission. But the gastric bypass in particular, both the Roux-en-Y gastric bypass and the single limb gastric bypass are particularly effective in putting diabetic patients in remission. Second option after the bypass would probably be sleeve gastrectomy, and then gastric band can also be used. And nowadays we have got an endoscopic option, which is endoscopic sleeve gastroplasty, which has also recently been approved by NICE, and that can also help in selected group of patients to help them put in remission from the diabetes point of view.
Are all of those equally effective, though? Because banding does require a lot of post-surgery management, doesn't it? And in the UK context, that wouldn't be your preferred option, though, for somebody with diabetes, would it?
Absolutely. I mean, you have just pointed out that different operations have got different effectiveness as regards to diabetes, and a gastric bypass is considered the most effective. In fact, the most effective option, which we tend not to use, is the bilipancreatic diversion or any version of that. So BPD, different versions would be the most effective ones, but it is very intensive to maintain those patients, and they suffer from a lot of nutritional effects, and therefore we prefer to use a gastric bypass in the UK setting. So both RY gastric bypass and the single anastomosis gastric bypass are effective, and which one we use will depend on the patient and the patient's other health conditions. We can, as I said, we can use the sleeve gastrectomy as well in a selected group of patients, and a gastric band is a distant third preference in UK setting.
Is sleeve gastrectomy as effective as the bypass, though, in terms of the proportion of people who will get the adequate amount of improvement or remission?
In our experience, less effective than a gastric bypass. Gastric bypass seems to be more effective, though international studies seem to show that the difference is small, at about 10% difference. But if someone has got diabetes control most in mind, then probably gastric bypass is going to be the best option. But sometimes a sleeve gastrectomy may be a better option in certain patients. For example, patients who had previous abdominal surgery, and a gastric bypass may be difficult to perform because there are adhesions, or the patient's got other health conditions, and therefore we want to do a quicker operation, simpler operation, and then a sleeve gastrectomy may be the preferred option.
Yeah. What I should add for the benefit of viewers, of course, is that, as usual, I'll be providing some text underneath the window containing this interview, and then there are some web links to sources which will actually have some diagrams and some explanations of some of these different types of surgery. So there will be some additional information. But you also mentioned the requirement for management afterwards in relation to nutritional status, because there is a need for supplements, isn't there? For lifelong supplements, and also monitoring as well on an annual basis.
Absolutely. Like many operations, we do have to monitor patients afterwards. when patients have cancer operations, it's not that we do an operation and we finish off with the patient. There is monitoring after that. And the same thing applies to gastric bypass patients and sleeve gastrectomy patients, and less so in the gastric band patients. They need micronutrient monitoring, and the common micronutrient that we advise are vitamin B12, folic acid, calcium, and some amount of iron, depending on the diet of the patient. And then sometimes other micronutrients are necessary. So copper, zinc are not so often necessary, but rarely that may become necessary. And we have seen other vitamin deficiencies as well. So we do advise a general multivitamin as well. So there are some reports of people developing vitamin A deficiency, and therefore they might need some supplements. But generally, a multivitamin, a good multivitamin with special supplementation of vitamin B12 and folic acid and vitamin D. And as far as the minerals are concerned, calcium and iron are commonly prescribed and advised, and we monitor these routinely.
Yeah. How good are people in the UK at actually adhering to that requirement? I mean, I know it varies from place to place, and obviously you and I have both seen patients who've not done what they were supposed to have done over the years, but overall, do we get good compliance with that, or is there a small percentage of people who sort of fall by the wayside and are not followed up?
Yes, a small proportion of patients do fall by the wayside, but in the UK, we have got a better joined-up health system. We're lucky than many other countries. So usually GPs are very good at sending out reminders, and as long as the GPs know what to do, their system set up, so there would be automatic reminders and they would do those blood tests. If patients sometimes fall through, so they have not actually attended intentionally, sometimes because other life events take over, then usually if they develop deficiencies, they will present with clinical deficiencies, and we can pick that up. And that is not uncommon for patients who are going abroad, because our experience is that people who go abroad for bariatric surgery, unlike the private sector here, where we are all geared up to it, and this is very commonly advised and stressed. And we have got the support groups which patients can attend and are attending lifelong. We find that patients who have their surgery abroad sometimes come back without any follow-up, and therefore they don't take the supplements. GPs are not aware of their having undergone bariatric surgery, and then they are picked up 1-2 years down the line when they have developed deficiencies, and that is quite common for people who are having surgery abroad.
Yeah. Now, you mentioned lifelong. Do people who've had bariatric surgery live longer?
Yes, population-wise, there is no doubt about it. So if you compare a group of patients, a large population of patients who, let's say 100,000 patients who underwent bariatric surgery after fulfilling the criteria, and those another group which did not undergo and just underwent diet and exercise and the best medical treatment, we know that the group that had bariatric surgery would by far have a much better mortality reduction. So those who would have gone through the diet and exercise would also have some benefit, but not to the extent that the bariatric surgery can provide, apart from the other health benefits as well. These patients can walk better, their sleep apnea, etc., and other health issues resolve, which is also a great advantage.
Yeah, so their sleep, obstructive sleep apnea, if they have it, is improved. Blood pressure is also improved, isn't it, as well?
Yeah, absolutely. And arthritis, one of the common problems with these group of patients are that they struggle to walk far, they become very short of breath, their joints are wearing out, and a lot of these patients, once they have lost 50, 60, 70% of their weight, excess weight, find that their walking and other activities have dramatically improved. They can do those things which they never thought they could do before.
Yeah. Now, one of the interesting things is that in the UK and in some other countries, more so in some countries than others, we've seen a change in the pattern of obesity with an overweight, with more people who are really very heavy. And I know that perhaps your sort of typical type of person who comes into the system is 160 to 180 kilograms, but you do also see people who are over 200 kilograms in weight. And these are, I believe, from our previous discussions, more challenging. And that raises the question as to what extent is some preoperative weight loss important in everybody, but then particularly in the really heavy ones? How important is it to do that?
So, in our experience, if people have had preoperative weight loss, structured weight loss, then of course it has a great advantage. First of all, it makes the patients fitter. So their perioperative risks are reduced. Their risks of developing clots in the leg veins or chest infection, pneumonia, etc., are reduced. The operative time is significantly reduced. So a patient who has a shrunken liver, we probably can do the operation in half the time than the patient who has got a big liver, who is more at risk of suffering injury, trauma. Thirdly, the operation itself is also going to be more effective because we can do a smaller pouch, fitting a gastric bypass, fitting a sleeve. We can go up to the hiatus better, which is the upper end of the abdomen, the belly. So we need to really go up as high as we can, and it is easier to do these things. If the patient has got other problems like a hiatus hernia, then it is easier to repair that hiatus hernia compared to a person who has got a very big liver. And finally, God forbid, if there is some complication, which can happen. Let's say that out of 200 patients, out of 300 patients, one patient has developed a bleed or a leak, which is less common in our series. We don't have that many. But if it happens, then it's much easier to handle when a patient has got a shrunken liver. To go in and to deal with it is much easier.
Yeah, and we should say the standard approach to trying to achieve that reduction of liver volume is to use a diet probably for as little as maybe 2 weeks or 3 weeks, because the rate of reduction of liver fat is very fast, isn't it?
It is. I mean, liver is the first place that we store our excess calories. Once we have used up our muscle glycogen stores, and then it is also the first place that the energy is released from. So the liver is the first place we find that it responds very quickly. And also the other thing we find is apart from the fact that the liver, when it shrinks, we find that the patients themselves, they start feeling better as well. I suspect that when the liver is not working very well, that itself contributes to patients' well-being as well. So yes, indeed, the liver responds very quickly with the liver shrinkage diet.
Yeah. If we go now to the sort of longer-term effects of bariatric surgery, because this has been undertaken for several decades now, there are some data sets, aren't there, particularly, for example, from Sweden, which tell us the outcomes. And if you look at the figures for the proportion who go into diabetes remission immediately after surgery and for 2 years and then at 10 years, they maintain that, but with time there's a sort of drift back. I mean, if you look again at the average weights of those people, after surgery, weight loss continues for maybe up to 2 years. Would that be expected? And then sometimes there's a bit of a drift back up a little bit.
Yeah. So absolutely, because the body is a system. So there is checks and balances. So if the body has lost a certain amount of weight, the body will always try to put it back to the old weight. But because of the altered anatomy and the altered physiology, change of hormone profiles, etc., the body doesn't quite manage to do that. So we find that the best weight loss is probably between 12 to 18 months. And after 18 months, there is a slight drift back upwards. And at about 2 years, that's the time when the body has more or less reached the static that would remain the new normal for a very long period of time. Now, there are two issues here. Number one, of course, of patient's lifestyle. So the patient hasn't changed their lifestyle and goes back to having the high carbohydrate, high sugar, large portion food, then eventually the weight trajectory will revert back, and the patient will come back to having the same old weight. Now, fortunately, the vast majority of patients don't do that, but a small proportion of patients do. And if they do, then the weight will come back. The diabetes remission will also fail. Our pancreatic capacity to generate insulin is limited, and by the time the patients arrive on our doorstep, especially these especially heavy ones, they have already lost a lot of their pancreatic reserves. So if you can do these operations earlier on, and a patient has got, let's say, 80% of the pancreatic reserve intact, there would, of course, be a slow loss of the pancreatic reserve over the years, but they would likely be able to maintain a longer disease-free remission compared to a patient who's coming on our doorstep is already, let's say, on insulin or 3 or 4 or 5 anti-diabetic drugs. And these patients obviously are struggling more, and their diabetes remission would probably of a shorter duration.
Is the actual bariatric surgical treatment and subsequent management cost effective as measured by the various techniques that the health economists apply to these procedures? So if somebody challenges and you say as well, why are you doing bariatric surgery? It's not, it's expensive. It requires constant lifelong monitoring by either the general practitioner or another practitioner. Therefore, you cost all those factors in. Is it cost effective? Because the person with diabetes, of course, should be able to stop most medications soon after surgery or immediately after surgery, if they're in the early stages.
So it has been shown repeatedly, as in studies in Australia and in the United States, and also some in data here as well, that bariatric surgery is very cost effective, and the payback is probably around 2 to 3 years' time. And the reason for that, of course, is not only that these patients are using less medication. These patients can become physically more active, so that they can become more active members of the society, less time off from work, less consumption of health resources going to the GPs, physiotherapy, painkillers, chronic pain clinic. And there is very interesting data from Australia that shows that the GP visits reduces by about 3 to 4 times. So 3 to 4 fold. So that is very interesting. And so there is no doubt about it that this is cost effective. And the question is how soon? It depends on the comorbidities, etc. But the payback for, there is a bit of perhaps a bit of perverse incentive here. People who have got many comorbidities would probably start paying back earlier, but the best results would be achieved by those who have their operation earlier on in their disease. And excess weight is a disease, because it is not only the diabetes. These patients, it's not uncommon for us to be referred patients who need cardiac surgery, who need hip surgery, knee surgery, and they will not be offered these, or even fertility treatment, because one of the other things that we forget is a lot of women are infertile because of that. And if we talk about road traffic accidents, it's proven that obstructive sleep apnea is a very common cause of accidents. And if you imagine as to how an accident can impact on not only the driver who is driving the vehicle, but the others who may be victims. So there is no doubt that bariatric surgery is cost effective on an individual level and on a societal level.
Yeah. So now, if my last question, I think it might be the last one, if I were to offer you an opportunity with adequate resources and the influence and power to do so, how would you increase bariatric surgery delivery in the United Kingdom? Because most of my colleagues would say that actually in the UK we're really not delivering anything like as much as they do in, say, Sweden or in the Czech Republic, where vastly more people have access to this, whereas in the UK people are not able to access it as easily as they perhaps should. How are you going to solve that problem?
Very difficult, as you know, Tony. The health system in the United Kingdom has been chronically underfunded for many years, and it's a matter of conflicting priorities. And if I had adequate resources, if I had no constraint on resources, that would be a different issue. Sadly, our politicians' horizon is 4 years or 5 years until the next election. And if they can do something quick, and cancer always catches the headline. You mentioned about cost effectiveness. I know of cancer drugs which cost 40,000, 50,000 pounds, 4 or 5 times more expensive, or even medication that is used for diseases like Crohn's disease, colitis, which can be really the biologics can be very costly. So it's difficult, but I think with raising the awareness, sadly there is some societal disadvantage. People do look upon obese people as if obesity is their fault. I think that there has been a lot of change, but there is still a lot to go. And of course, I think we have to attack it at all levels. It's not only bariatric surgery. There is a role for the community. So it starts, as we know, obesity is a disease that starts young. So it is affecting more and more of our youth. 25-30% of our young people are overweight and obese. So that needs to be tackled. Medication needs to be prescribed early. We have got things like liraglutide and semaglutide injections. They can be used, and we should use all sort of modalities. But yes, I think if I was given the option, I certainly would fight for bariatric surgery to be offered more easily, and we need more surgeons to deliver this. So we need more beds, more surgeons. It's a long ask. I'm not sure that it would be easily achievable, but I think if you can do that, that'd be great, because it will heavily impact on the outcomes of so many other conditions.
Yeah, thank you very much. Thank you. So with that very comprehensive answer, which is, if anybody wants to know how to solve a problem, that's how you solve the problem. So thank you very much, Pratik Sufi at the Whittington Hospital in London, for talking to us. Thank you.
Thank you. Thank you very much, Tony.
Thank you.